Good afternoon. Thank you for joining us for this webinar to help empower you with up-to-date clinical information and assist you with result interpretation. This is a brief educational webinar examining the interpretation of positive cocaine results from Aegis Sciences Corporation. We will discuss positive results and the relatively unexpected potential causes of positive results as well. Takeaways will include understanding two known unexpected sources of cocaine, understanding the likelihood of passive exposure to cocaine, learning about potential routine everyday exposures to cocaine, and understanding consultative options to aid with result interpretation. Those who missed the live presentation or would like to hear it again may find a recording of this presentation on the Aegis website at www.aegislabs.com. Call 1-800-533-7052 if you need assistance accessing the recording. Cocaine use dates back as far as 5,000 years ago with the chewing of coca leaf in South America. It was isolated from the erythroxylon coca plant in 1860 by a pharmacist in Germany, Albert Niemann, and became widely used in medical practice as a local anesthetic after an ophthalmologist from Vienna, Karl Kohler, demonstrated its use as a local anesthetic in an ophthalmologic surgery in 1884. This event laid the foundation for cocaine's use as a regional and local anesthetic. As a fun fact, cocaine was used in Coca-Cola from 1886 to 1904 when it was ultimately removed. However, a flavoring agent from the coca leaf is still used today. One company that imports coca on behalf of the company, and they extract that flavoring agent and send it to Coca-Cola, and then isolate the cocaine from the leaves and send that to a U.S. manufacturer of pharmaceutical-grade cocaine. Interpretation of cocaine results differs when considering presumptive versus definitive testing methods and may also differ among laboratories. The information provided here is intended to assist providers with deciphering positive cocaine results from Aegis, which may have undergone definitive testing by liquid chromatography, tandem mass spectrometry prior to reporting. We will now begin discussing several possible sources of cocaine which may or may not be considered when evaluating a positive cocaine result. These include medical procedures, coca tea, occupational exposure, passive exposure, and intentional contact with illicit cocaine. As mentioned earlier, cocaine is available for medical use, and it's available as a 4% or a 10% topical solution, and it's used in very select medical settings for its vasoconstrictive and anesthetic properties. Known medicinal uses of cocaine include ENT procedures, minor lacerations, dermatologic procedures, and certain gynecologic procedures. However, given concerns for its central nervous system and cardiovascular adverse effects, the regulatory issues, and the potential for addiction, its use in medical practice has significantly declined as use of safer alternatives has been encouraged in the literature. Is a 2004 study, which is a survey of ENT physicians that revealed 65% had administered cocaine in the previous 10 years. That was compared to a similar survey from 1977, where 92% of ENT had used cocaine as part of a procedure. So it's worth considering that application of a topical cocaine medical procedure may result in a cocaine positive result, likely up to 2 days post-procedure. Coca tea is derived from the same leaves that are used to synthesize cocaine, which do contain cocaine along with other alkaloids. The tea is commonly ingested legally in South American countries, particularly in Peru and Bolivia. Tea which will contain variable amounts of cocaine, may cause mild stimulation and euphoria. Importation of coca leaf requires registration with the DEA, although coca teas containing cocaine are readily available on the internet despite their illegal status. Natural coca leaf contains 2 to 6 milligrams of cocaine per bag. To compare, a line of cocaine usually contains 20 to 30 milligrams of cocaine. Based on previous research from NIDA, the National Institute of Drug Abuse, on average it takes about a half milligram to 1 milligram of cocaine to produce a positive urine test at 300 nanograms per mil. And our threshold at Aegis is 50 nanograms per mil. Studies of coca tea ingestion have demonstrated positives for the metabolite of cocaine, which is benzoylecgonine, referred to as BZE throughout this presentation. And that BZE metabolite can be at concentrations over 4,000 nanograms per mil. The leaves of the coca plant can be decoconized, much like coffee can be decaffeinated. However, if a patient is ingesting coca tea and they test positive for cocaine, they should be informed that they're legal to possess in the United States. Occupations involving excessive or frequent exposure to cocaine, such as crime lab personnel or providers administering cocaine during an EM procedure, results in cocaine detection on a urine test. However, proper use of personal protective equipment reduces the likelihood of positive results due to occupational exposure. Involving physicians administering a single dose of cocaine to a patient, the maximum BZE concentration in the group of physicians wearing a mask with no gloves was 53 nanograms per mil 8 hours following the exposure. When the group was wearing gloves and a mask, the results were negative for BZE. So again, the personal protective equipment is useful to minimize the possibility of a positive exposure. One physician in this study was asked to handle cocaine for 2 minutes and wait before hand washing, repeating every 2 hours for 6 hours on day 1 and every hour for 6 hours on day 2. This physician experienced a maximum BZE concentration of 45 nanograms per mil, and that was at 18 hours following exposure. A study of crime lab workers showed 3 out of 9 subjects had levels of BZE greater than 50 nanograms per mil, which again is our threshold at Aegis, and that was after analyzing solid dosage forms, and the maximum level was 227 nanograms per mil. Levels in 2 criminalists handling a large amount of cocaine in a small room that did not have a fume hood measured up to 278 nanograms per mil, wearing a face mask and gloves, and up to 1,570 nanograms per mil when wearing gloves only. Another group transferring cocaine back and forth to each other over 25 times did have positives above 50 nanograms per mil while wearing gloves, mask, goggles, disposable, and a cap. Although these occupational exposures are going to be extremely rare, it should be considered when you have a positive cocaine result to make sure that there's not a justifiable reason that someone is positive. Passive exposure is a common excuse by individuals for illicit positive results in urine. However, the majority of passive exposure claims are unlikely to cause a positive result. Exposed to heated cocaine in a small unventilated room for 1 hour had urinary BZE concentrations up to 123 nanograms per mil at 5 hours following the exposure, with the BZE concentrations falling what would be a threshold of 50 by 15 hours. Another study exposing an individual to similar unventilated an amount of volatilized cocaine for 30 minutes showed no positive findings above what our Aegis threshold of 50 milligrams per mil would be. Realistic scenario, individuals were passively exposed to someone smoking cocaine with occasional ventilation for hours, and there were no positive results above the Aegis threshold of 50 nanograms per mil. Another study involving touching a cocaine-coated product all day, and another involving application of topical cocaine without washing, resulted in low levels of BZE up to 72 nanograms per mil and 55 nanograms per mil, respectively. Exposure to that product was over 13 hours. And so again, that may not be a typical exposure that anyone would see in the public. Patients have reported a multitude of passive exposure scenarios, such as disposing of a family member of cocaine, helping a friend cut cocaine, and being in the presence of individuals smoking cocaine. While these scenarios are unlikely to cause a positive result, these excuses may offer insight into the patient's social environment, which may be considered when utilizing risk assessment tools. From what we normally think of as regular cocaine use illicitly, cocaine has been described as being adulterated with or contaminated by other drugs. The DEA has reported seizing cocaine with fentanyl or fentanyl analogs. In many cases, these can be counterfeit opioids made from drugs like oxycodone, hydrocodone, or alprazolam. In addition, there are also anecdotal reports of individuals who lace their own marijuana with cocaine. So if you have someone who smokes marijuana, may or may not be cocaine in that marijuana. While these may, again, not be common occurrences, you may have certain individuals who may be more likely than others to be at risk for this type of exposure to cocaine. Cocaine has been reported to be on many public surfaces. A study published in 2011 analyzed a subset of typical public surfaces in a working to upper middle class area of New Haven, Connecticut. While they did use an immunoassay technology, which may be subject to false positives, most fuel pump handles tested, buttons, shopping carts, and small shopping mall tested presumptive positive for cocaine. In addition, another consideration is a study from 1996, which found that cocaine was on 79% of U.S. paper currency at a threshold of 100 nanograms, 54% of currency above a threshold of 1,000 nanograms. While the amount on currency may be too small to give any stimulant effect, the possibility exists for the cocaine to be transferred to an individual's hands as a result of handling those surfaces. This is an important consideration when conducting oral fluid testing in particular. Because an individual who does not necessarily use cocaine can have it on their hands as a result of touching contaminated surfaces or money, it is advised an individual should wash their hands thoroughly before touching the oral fluid collection device. Greatly prevent the accidental transfer of cocaine from a patient's hands to the collection device. For more information, instruction document on proper oral fluid collection technique, please contact the Aegis clinical team. As we conclude, I want to pass along the contact information for the clinical team here at Aegis. Our team is ready and willing to take your calls and emails regarding today's content or any other questions that you may have about result interpretation or drug testing in general. Information covered today is also available in a written form accessible online at www.aegislabs.com. Navigate to resources, then clinical update.